Next, I'd like to introduce the Associate Dean for Practice here at the school, Dr. Matthew Bolton, who will give us an overview of the day. Thank you.
I was asked to provide brief comments to frame today's symposium on disasters and public health preparedness. Our Dean, Ken Warner, has referred to our current students as the disaster generation, which is not a reference to their personal lives, but rather alludes to the fact that they have entered their public health training amidst a veritable panoply of national and global disasters. The first arrival of West Nile virus in the Western Hemisphere, the horror of 9/11, the debacle of Katrina, the unimaginable devastation of the Asian tsunami, and the ever-present threat of pandemic influenza. It may seem to these students that emergency preparedness has always belonged to the parlance of public health, but this is not so. Although several of the speakers you will hear from today have spent many years studying, planning for, or responding to disasters, public health as a discipline and as a system was, until the last few years, largely removed from the preparedness picture. Only after our country's leadership slowly came to realize the central role of public health in preparing and responding to widespread infectious disease outbreaks and other catastrophic health events were we invited to the table and brought into the national discussions. A large and sustained infusion of federal monies into public health has followed, but after decades of neglect and severe underfunding, the public health system, not surprisingly, has mostly received failing grades for emergency preparedness response capacity. Many years ago, I was the regional medical director for a 3 local health department jurisdiction, including Washtenaw County, and in that role, I had my first exposure to small-scale disaster drills. From those limited experiences, I quickly realized 3 things. Number 1, I knew nothing about disasters. Number 2, I knew even less about responding to disasters. And finally, number 3, if there ever was a disaster and I was in charge, it would be a disaster. Consequently, in the mid-1990s, I anxiously enrolled in an APHA conference workshop taught by Dr. Eric Noji, today's first speaker, on public health response to disasters. I learned much in that workshop, and years later, when I became the state's chief medical executive, that training served me well when I had to lead the state's response to a massive explosion of a train carrying methyl mercaptan in the middle of Detroit. 3 workers were immediately killed in the explosion, and many others were seriously burned or injured. As the fire crew hosed down the burning train wreckage, the chemical began to wash in the Detroit River, the source of the city's drinking water, and a volatilized plume began blowing over the northeastern part of the city. I was asked to make decisions regarding the shutoff of the Detroit water supply, about evacuating 15,000 persons in the path of the plume, and about setting up a field triage center for the injured, and that was all in the first hour of the crisis. Many, many things went wrong that day with our response, and I'm sure that more people were injured and perhaps even died because of our lack of a public health preparedness system, but we have come a long way since that time. We ask today, are we prepared? But preparedness is almost never an absolute, a yes or a no, although the public, politicians, and especially the media would often like to make it so. Preparedness is a process, not a point. And today we will hear about disasters in all their dimensions from an esteemed group of national experts. From Dr. Susan Cutter's research into what makes people and places where they live vulnerable to extreme events and how to measure that, to Paul Kleindorfer's cutting-edge work on modeling for natural disasters and pandemics. We'll hear from our own Dr. Sandro Galea on his fascinating look into the mental health implications of disasters, and also from my long-time colleague and friend, Dr. Dean Cinco, who will discuss public health and war from his very unique perspective as both a public health practitioner and a brigadier general in the U.S. Army. Our first speaker of the day, however, is Dr. Eric Noji, and I can think of no one more eminently qualified to lead off a symposium on disasters than him. Dr. Noji is a physician who recently joined the Center for Disaster and Humanitarian Assistance Medicine after a distinguished 18-year career at the Centers for Disease Control and Prevention. At the CDC, he had extensive domestic and international experience in responding to natural and technological disasters, terrorism, violent civil conflict, epidemics, and wars resulting in hundreds of thousands of forcibly displaced persons and other humanitarian crises. His last CDC assignment was serving as senior policy advisor for emergency and humanitarian assistance to the director in Washington, D.C., where he was responsible for working with Congress, the White House, and other executive branch agencies related to emergency preparedness and national security. Dr. Noji is the author or co-author of over 200 articles and publications on disaster medicine, disaster epidemiology, clinical toxicology, medical response to terrorism, and complex humanitarian emergencies, including the most widely used textbook on these topics, The Public Health Consequences of Disasters. Dr. Noji was elected to the Institute of Medicine and the National Academies of Science in 2005. I will also mention that the Eric Noji Excellence Medal is awarded annually by the Department of Defense's Center for Excellence in Disaster Management and Humanitarian Assistance. And I don't know about all of you, but I would love to win a medal as opposed to simply having one named after me. And so, Dr. Noji, after almost a decade after I took your disasters workshop at APHA, I'm intrigued as what new things you have to teach me and the students and faculty of the University of Michigan School of Public Health about disasters and public health preparedness. Dr. Noji.
Thank you very much, Dr. Bolton. I'm absolutely delighted to be here, and for a variety of reasons, I have relatives here in Ann Arbor, and have had the great pleasure of visiting over many times over the years to one of my favorite places, a very scholarly academic community with a good football team. And this also is very gratifying to me to be able to give a lecture at a distinguished university, because I remember as a young faculty member at the Johns Hopkins School of Medicine, which is very competitive in terms of survival of faculty tenure advancement, I made an appointment to see the the Associate Dean of Research, to get his advice on career development. And I remember going into his office and and him asking me, well, what are you interested in? Genetic research, infectious disease. Oh, by the way, what type of bacteria or virus? And I said, well, I'm interested in disasters. And after he picked himself off the floor, he said, son, I think that your career here at Johns Hopkins is going to be quite short. We would like to prepare our faculty to specialize in a very narrow area and to become the world's expert, whether it's one bacteria or part of a bacteria or part of mitochondria. And disasters are a little bit broad. And basically, after being told to go play in the street, and very discouraged, I made the decision to go to the Centers for Disease Control, which had actually major responsibilities for responding to disasters. And my goal, I guess my dream, was to establish disaster medicine, disaster public health, as a genuinely respected field of scholarly endeavor. And after that dressing down by the dean at Hopkins, to get the respect of my colleagues at such an institution by publishing and making this field one that is credible of the respect of one's peers, and being elected to the Institute of Medicine based on this work was both a great personal honor and I think a reflection of the growing respect that disasters have now, particularly since 9/11 and the anthrax crisis and multiple major refugee crises like the forgotten one in Darfur and in Congo, where we've had 4 million people die over the last 5 years. No one really knows about that. But for a variety of reasons, disasters are now well-funded for research. And they're probably, in 1999, I counted about 3 institutions globally that had disaster epidemiology or public health centers or divisions at the schools of public health. Now, if you do a Google search, I think it comes up to about 10,000 from high schools all the way up to the University of Michigan. And this first time I've ever mentioned this, but I almost ended up being a graduate student here. When I was an undergraduate at Stanford, I wanted to become a biologist, and my major area of interest was avian migration, and had spent summers working at ornithological research stations at Cape Cod and whatnot. And the one bird that fascinated me was the Kirtland's warbler, which, as you can see from this map, it might be hard to see, is only found in certain counties in Michigan. And I applied to the Department of Biology here and was accepted. And then I, coming from an area of the country, very perfect weather, and I started to think about this. And I started to obsess about that and how much I enjoyed California weather. In fact, growing up, I never saw snow before I was 22 years old. At any rate, it was because of that I made the decision to switch from biology to medicine. But little did I know that this early interest in birds has come around full circle, since the last 3 years of my life has been almost 100% working with avian influenza in China and here in the U.S. As Dr. Bolton said, this has been a natural extension of my work in a variety of disasters, natural disasters like earthquakes, hurricanes, floods, volcanic eruptions. Interestingly enough, since 9/11 terrorism, even transportation disasters, the fallout from the Challenger disaster, surprisingly enough, had significant public concern about the health and medical impact of the actual parts of the Challenger, and CDC was involved in that. Technological disasters, chemical accidents, radiological, nuclear power plant disasters. In fact, one of my major responsibilities coming to CDC was to lead the unit that would respond to types of disasters like Chernobyl, which had just recently happened, and the Bhopal Union Carbide methyl isocyanate disaster that had occurred in India with 10,000 deaths. Chernobyl, we still don't know what the long-term fallout from that will be, cancers, particularly thyroid. And I'd never thought of this before, but perhaps generations with significant genetic changes. I'd always thought, as we all do, disaster hits, you've got an immediate effect on on the population, and you respond, and things go back to normal. Well, they don't. Hurricane Andrew, 14 years ago, which I was heavily engaged in. I'm still involved in a cohort study following long-term chronic diseases, mental health, depression, anxiety, employment, and incredible people who had jobs on August 23rd, 1992, when Hurricane Andrew struck just south of Miami. About 35% of people who had jobs then are still unemployed. Significant increase in mental health problems and chronic diseases. So these are issues which a lot of people don't think about when they think about disaster research. At any rate, with the incidents of with the bioterrorism attack and the occurrence of the SARS event, and now the threat of H5N1 pandemic influenza, we have to deal with the specter of pandemic diseases. I'd worked with many, well, now I call them smaller epidemics, when in fact they're not. I worked in eastern Zaire, 1996. We had 1 million refugees from Rwanda cross into the country, and within about 3 weeks, epidemic of cholera, or what we think was cholera, followed by what we think was Shigella dysentery type 1. 50,000 people died of diarrheal diseases, but as was mentioned by Dr. Bolton, that's just virtually a fraction of what we would see in a global pandemic. Certainly, the last 10 years, even before 9/11, there have been no shortage of major disasters, many of which have affected the economy of countries which simply can't afford to respond to a disaster. If you look at Hurricane Mitch, 1999, I don't have that up there, but in some countries like Honduras or Guatemala, the amount of resources expended by the Ministry of Health for one disaster was the whole year's allocated budget for public health. And these countries still have not recovered from that hurricane, and there's still a State Department project on Hurricane Mitch reconstruction. So one thing I wanted to emphasize is the effect of disasters just don't happen, and you have relief. Unfortunately, most relief efforts and CNN and the media leave, and the countries are pretty much left on their own with the specter of years of recovery, like in Armenia, for example, 20 years ago, and you still have people who are homeless as a result. More recently, of course, Hurricane Katrina, the tsunami, the earthquake, probably the greatest disaster, I should say Sudan and Congo, former Zaire, is the greatest disaster ongoing right now. 4 million deaths, I mentioned. First time I've ever seen it focused on is it's going to be on, I think, on CNN, focused on that particular crisis and the one in Sudan. But that's pretty remarkable. My experience had been pretty much up until the mid-90s natural disasters. Armenia earthquake, Mexico City earthquake, Hurricane Andrew, eruption of Mount Pinatubo. And I think today, talking about natural disasters, we have two major, another reason why I think this is such a appropriate time to have this symposium focus on disasters, because of two events that we are, I shouldn't say celebrating, but we're at the 100th anniversary of the Great San Francisco earthquake, which occurred in 1906, where most of the deaths occurred from the subsequent fires which broke out. And 20 years, April 26th, 1986, 20 years since the greatest nuclear accident, radiological accidents at Chernobyl in 1986. So we're at the 100th anniversary of the San Francisco earthquake and the 20th anniversary of Chernobyl. We're also in a situation where I mentioned that most of my career had dealt with natural disasters, factory, occupational accidents, refugee healthcare, particularly with the collapse of the Soviet Union. We had major crises due to ethnic animosities unleashed in the Balkans, Sudan, Somalia, Mozambique, Angola, Sierra Leone, Liberia, all places I worked in. Most when I was detailed for 5 years to WHO in Geneva, but certainly since 1995, probably, with the attack on the federal building in Oklahoma City and the sarin chemical weapon attack in the Tokyo subway system, the largest and most complex subway system in the world, and 2 weeks later, the Ebola virus epidemic in Zaire, and the specter of widespread infectious diseases, when in fact Ebola is not terribly infectious. This changing threat, terrorism, chemical, we had passage of legislation, small amount of money allocated, and another great turning point in my life was I'm very happy in Geneva. I worked for a CDC staff who had been at at World Health Organization for 20 years as a CDC secondment, and that was Dr. David Heyman. And I had anticipated 20 years in a hardship post like Switzerland, with skiing 20 minutes away and sailing on a lake. When I got a call from CDC to return to become the deputy of a new bioterrorism program, and I couldn't believe it. Bioterrorism, that's crazy. Very, very skeptical. When I got there, we had a staff of 3 people. The director, Scott Lillybridge, myself as deputy, and a support person. Over the course of the next few months, we got up to about 25 people. But what made like I said, I was in a bad mood for about, the whole time I was back in Atlanta, after 5 years in Switzerland. But this whole, around the world, began to see increased terrorist bombings in Israel, bioterrorism. I was still, I was chemical. I was very concerned about because of the sarin chemical weapon attack and the fact that a cult group can manufacture it. Blast terrorism, of course. Oklahoma City, the attacks on our embassies in Tanzania and Kenya. Bioterrorism, I was very skeptical, but what made a tremendous impact on me as a government employee was this quote from very well-known senior-level government scientist, Tony Fauci, the director of the National Institute for Allergy and Infectious Diseases. And I think it was around June 2001, in Clinical Infectious Diseases, very prestigious journal, Tony said, a bioterrorism attack in the 21st century is inevitable. And for 2 reasons that made an impact. Eminent scientist, a great scholar, and also a government official. And senior level government officials rarely, as we've seen in the last couple of years, and documented quite well in the book by Bob Woodward, which I don't know if it's come out yet, but if it hasn't, maybe tomorrow. But government officials, whether they're scientists or politicians or both, rarely are so blunt. And when he said that, I began started to change my mind a little bit, and it really got changed, of course, on an event which changed all of our lives. Everybody who visits this country, every time you go through the airport, and in a variety of other ways, and unfortunately, in more ways in the next few years. If what I've read is true of the increased security precautions, and every time there's something like an event in London, for example, when they recently caught 20 individuals who were planning to conduct suicide attacks similar to 9/11, we have an upsurge in legislation dealing with immigration issues, border security, and potential lessening of our constitutional and civil rights, which concern me quite a bit. But this event, I would have to say, brilliantly conducted, coordinated. We see that right now in a very formidable foe in Iraq. But this event, this was when I was actually called out from Atlanta to help coordinate the response to the World Trade Center because an enormous amount of federal resources poured into Manhattan, personnel, medical teams, search and rescue teams, environmental health because of the dust which was created, mental health professionals. I shouldn't say this, but fortunately, there were very, very few survivors. Had there been, it would have totally overwhelmed even the massive number of federal assets that flew into Manhattan. But the collapse was of such a catastrophic nature, and the nature of my research previously in earthquakes had been the relationship epidemiologically between building collapse, materials, architectural design, human behavior, and mortality. Of course, this was obviously the worst. And if you came back a month later, the temperature in the pit was still well over 1,000 degrees. Survival just pretty much impossible. In fact, the day I was supposed to go home because of the rapid decrease in acute need for federal response to the World Trade Center was a rumor of a case of anthrax in Boca Raton, Florida. And everybody in Health and Human Services, and I was working directly in the office reporting to Tommy Thompson, they said it's a hoax. But can you stay one more day? I said, okay. And of course, there were many comments by senior officials in HHS who were not health professionals, at any rate, that were not exactly correct. But at any rate, this was not a hoax. And of course, another brilliant attack using the postal system. Who would have thought? A vehicle which could spread all over our country and globally. And we still, actually, law enforcement still has not caught the perpetrator. Although we've had a couple people of what they call of interest, no one has been arrested for this incredible event, which has changed CDC, which has changed our government, the World Trade Center, and the anthrax incident. When you think of anthrax, we had 23 people with inhalational anthrax, and five deaths. 18 people survived. The last case of inhalational anthrax was investigated by, he's now a professor of epidemiology at Emory, but at that time was a young epidemiologist at CDC, Phil Brockman. The mortality in 1957 was 100%, so certainly an improvement in survival, but what has that done? It's resulted in the creation of the largest reorganization of the U.S. government since 1947, when they created the Department of Defense out of the Department of the Army, Department of the Navy, Department of War. And there's some arguments that the Pentagon still has not become well coordinated despite 60 years in existence. We've got a new department with 220,000 people mashed together from 22 different agencies with a budget of $38 billion, the Department of Homeland Security. And when you think about it, at CDC, our budget, on 9/11, our budget was about $150 million. The budget now is, $2-3 billion. Maybe over when I left CDC, it was about 25% of the entire CDC budget. As you recall, when I got to CDC in late 2000, returned to Atlanta, our staff was 3 people, 100% devoted to terrorism. Now we have 800 people devoted to terrorism, and a budget for terrorism which probably exceeds, in fact I think it does, the HIV/AIDS budget, which even though I was in the bioterrorism program, and usually when you have a budget increase, you're quite happy, I still was very confused, and it was because I knew globally HIV/AIDS was a far more significant public health problem, and but once again our budget was going up, and the AIDS budget at that time was staying pretty stable. But this was a terrible time for CDC. In fact, this changed CDC and all of public health in many different ways. And when we talk about the changes since the last seminar, this is one of them as a result of the anthrax crisis. Trying to make decisions when you don't really know what's going on, when you're dealing with other types of disasters like I did, hard drive failure with smoke coming out of it. It really changed our whole approach. That dealing with the media and trying to solve a outbreak and trying to do science under the glare of global media, BBC, CNN. Every day I went to work, this is what I felt like I was coming into, because there would be a pile of return message to Larry Altman at New York Times, return call to so-and-so at CNN, BBC, International Herald Tribune. But can you believe it? Despite 50 years of CDC history, we had never had a press press briefing with like you see in the White House. We forgot one of the great tenets of public health, and that's public education. But dealing with an organism which was, unknown. We knew anthrax. Okay, we got 30 to 40 cases a year. All cutaneous anthrax, usually in the Midwest area, in areas of livestock, agriculture, but this type of anthrax was, for all intents and purposes, a new organism, what the military calls weaponized anthrax. And I probably read every book I could find in the infectious disease and military medicine literature, all of which turned out wrong in terms of the behavior of anthrax. It said if anthrax gets on the ground, it can't be re-aerosolized. The physical properties of anthrax were such that inhalational anthrax would be very rare unless you were a wool sorter. That's what it was called many years ago, wool sorter's disease, because they're working in imported wool and particles, and they're inhaling it. We didn't know how many particles were required to actually cause a person to show symptoms, let alone die. But to give you an idea of the nature of this type of anthrax, which we now know was aerosolized. I was in Washington at the time. We had sick people and deaths from a postal, kind of like a triage center, a main postal center, not a postal office, where it was kind of warm. And if you see the way mail is first processed, it goes into these turbines and it's whipped back and forth and round, and it was warm in there, and they had fans on. And the people who died were in that room, and it was quite obvious that the anthrax coming out of the envelopes, and when I say coming out of the envelopes, I mean right through the envelopes. We did electron microscopy of the envelopes themselves, the pattern of fibers, and even an envelope has holes in them. The anthrax spores of that weaponized nature went right through. And when it was going through that very vigorous process, it would get right out of the envelopes, get on the floor maybe, re-aerosolize, and into a person's lungs, and not documented in the literature. So something that we didn't know. And I just put this down. I'd say the main we talked the commandment, 10 commandments at CDC. Number one is data for decision making. That we do epidemiology, we do investigations to allow decision makers and whoever they are to make better decisions. But what do you do right in the middle of an emergency, having to make decisions with no data, no experts? The press always asking, what is the risk? Should we expect more deaths? Is the epidemic over? Now we've got a case in Washington, in addition to Florida. Now we've got a case in Connecticut. Now we've got a case in New York City, with the cutaneous case with Tom Brokaw's assistant. So the major lesson there was need a coherent, rapid process for addressing scientific issues in the midst of crisis. Our scientists, laboratorians, and epidemiologists at CDC, they were being inundated by phone calls from the media. There was no protection, and trying to solve this mystery and develop some intervention, and at the same time being interrupted so frequently made this doubly difficult, and that's led to significant changes at CDC, which I don't want to go into right now. As I said before, despite incredible public health achievements in a 50, 60-year period, polio in the 50s, smallpox eradication, Legionnaire's disease, hantavirus, response to many disasters, the HIV epidemic, the emerging diseases in the early 90s. We had never had a press conference at CDC. We had individual interviews, but we really didn't know how to deal with the media and effectively communicate risk. And that, basically, we didn't do a very good job. And kindly, we probably screwed up a little bit. And of course, when it's in the New York Times, it gets worse. Efforts to calm the nation's fears spin out of control, and this is a part of disaster public health, which many of us had never thought about. We learned many other things, that it's good to be organized in the communication, public communication, supply of medications and other medical equipment. We used to do things like this, and it led to a vast expansion of the strategic national stockpile, several stockpiles placed around the country in undisclosed locations, I guess that's where you can find Vice President Cheney, maybe. But with various medications, and we changed the name from the National Pharmaceutical Stockpile to the Strategic National Stockpile, because now it's got equipment like ventilators and antidotes and things to do in the case of a nuclear attack, blast terrorism, and well-organized warehouses. Once again, asked to talk about changes in the last 10 years. And this has been a major change, and that's because of the funding. We went from 3 centers, public health, schools of public health, to now, at CDC, let's see, with our initial money, we funded 3 centers, and then now I think centers of what they call public health preparedness is up to about 50. And, excuse me, this is the epidemic curve here. October 2003, and each I was just following the new ones that I read have been established. Unfortunately, at many institutions that have really no expertise in these areas, the role of universities in disasters, and as I said before, from being very depressed very early in my career at being told that disasters was a field not worthy of scholarly investigation or research, to now a very prominent role for the academic scholarly community. And I just listed some of these characteristics of the academic, public health, and medical institutions that would be very valuable in the event of a major disaster. We have major organizations. This for physicians, the Association of American Medical Colleges. They're the ones who certify medical schools. They're the ones who publish, probably now on the web, all of the residency programs and internship programs you can apply to medical schools. Here they published a report, Training Future Physicians about Disasters. Never would have seen that 10 years ago. The AMA has a Center for Disasters. There is a new journal which is going to be coming out, published by the American Medical Association on disaster public health. Once again, by the most influential medical organization probably in the world, American Medical Association. So not only do we have increased research questions to answer every time there's a disaster like Katrina, World Trade Center anthrax. This is one area which hundreds of millions of dollars, not only in health, are being expended by FEMA, by the Department of Health and Human Services, by state health departments on preparedness. But they always used to get mad at me because I would ask, well, what do you mean by preparedness? And I always thought back to and they would say, well, you know, we've got 1,000 doctors and we've got 10,000 EKG machines and a billion ciprofloxacin pills, and we're ready. We're prepared. Then I was thinking back to a very eminent University of Michigan professor, Donna Bedian, and I took courses on quality assurance and measures of effectiveness, and I was just thinking, preparedness, is that just what Professor Donna Bedian said was structure? That means, okay, we've got a place to put contaminated patients if they've got sarin or VX on them. Process, okay, we're drawing blood for tox screens on so many patients. But one thing we don't have, because we don't have that many disasters, really, is outcome measures. These are just some of the questions of the criteria for preparedness. And I don't mean this as a criticism, but CDC is struggling with this because I shouldn't say but CDC is giving out lots of money, and Congress, for some reason, wants to know that money is doing some good, and usually it has to be quantified. How do you quantify preparedness? Metrics, basically, is what is referred to, quantitative tool to measure performance and effectiveness. against an established standard or model of disaster preparedness or response. How do you do that with one case of anthrax attack, one really horrendous disaster like Katrina? The bottom line is we currently have no metrics for preparedness, regardless of what people say. When we talk about the growth and maturity of a topic, whether it's astronomy or informatics, or areas with genomics, proteomics, you've got to have people interested in the topic. You've got to have the support of senior members of the faculty, the dean. You've got to have funding, and you've got to do research, and you've got to publish that research, and it has to be disseminated. And it's amazing how fast we've come in disaster medicine, where we've already got probably 5 or 6 journals 100% devoted now to publishing the results of disaster medicine and disaster public health research. International Journal of Disaster Medicine, I said before, the AMA in about 3 months will be coming out with their own journal on disaster public health to publish the results of disasters, which now we've got university centers and we've got faculty who can devote their careers to this major public health problem. In CDC, they're so busy with responding and having to jump from one topic to another, and there's no grad students. That's another area where I think the academic community can make a major contribution, is time and the personnel and people to do these studies, and now we've got funding. But did we learn? One of the depressing things is that we've got 30, 40 years of published articles spread around, albeit, but did we learn much? And this was very depressing for me the last couple of months of my career at CDC. This is Hurricane Katrina wending its way through the Gulf of Mexico. And of course, we all know the impact on New Orleans, which any of you who have been to New Orleans, you know that much of the city is right at sea level. The Mississippi River, before it empties into the Gulf of Mexico, it goes right through the city. Many parts of New Orleans are even underground. And I always found it fascinating that you go to cemetery in New Orleans and you see these tombs above ground, like walking along a Roman road like the Appian Way in Italy. And that was because if they buried people underground, you'd have a situation of coffins floating down the river. And this has been known for years. FEMA, 1 month before Hurricane Katrina, had an exercise that was almost identical to the scenario, but we made the same mistakes. We have, and I just don't want to bash on Louisiana, California. We've known about the San Andreas Fault for years. We've got a large history of earthquakes. This is near, actually, where I was an undergraduate at Stanford. But this major interchange is right over a major fault in California. You can imagine earthquake, the destruction of a major transportation artery, and that means no assistance is coming in. And I learned that during the San Francisco earthquake in 1989, October 17th. I only remember that because it was the World Series earthquake when, I don't know if you remember, but the Giants were playing the Athletics, the Bay Area, and the TV screen went out right in the middle of the game. But one road to Watsonville and Santa Cruz, there was a landslide, and no assistance got there for a couple of days. People like to live in very beautiful, aesthetically pleasing parts of the country, like the coast. And over the next few years, something like 75% of the U.S. will live within 50 to 100 miles of a coast. This is my college roommate's house, and I keep on telling him for years that, you better better be careful. Maybe you shouldn't live there, and it's very vulnerable. And he said, no. And he still thinks right there living there that it's not very vulnerable. I'm just joking. He doesn't live. That's taken from I think a National Geographic magazine. This is Kobe, Japan. One major freeway, highway coming into the city, and that delayed the provision of medical assistance because in Japan, the whole concept of aeromedical medical care, aeromedical evacuation, hospital-based helicopters was unknown, and so there was nothing coming in by air. And then from Katrina and what I found again and again in WHO, massive bureaucracy. This probably is the major problem that we have to address. Institutional problems, structural problems, administrative problems, and all of these are detailed quite extensively in the congressional and GAO reports on the problems in the U.S. government, federal, state, and local response to Katrina. Let me go. These are other issues which the academic community, training. We did a survey of, I think it was at Hopkins, and of the entering MPH class, about 70% of them were interested in public health emergencies, and whether they made it a career or whether they went to state government and became a state epidemiologist or even responsible for STD programs. I can tell you when there's a major disaster, everybody switches gears, and whether you're involved in mental health services, maternal and child health care, HIV, you do disasters, and during anyone's career in at least government public health, you will do a disaster, a tornado, a flood, an earthquake, a plane crash, a factory explosion. What the future will hold, I've already discussed a little bit of this. I didn't discuss the fact that we have increasing population density, unfortunately, in the most vulnerable parts of the world. This increase in just doing a bar chart, I don't think that's because we're having more disasters, but we just have more people in the world that would be affected by a disaster. And this chart reflects human impact. The whole issue of megacity development, that's addressed more in demography, but these cities are cities like Mexico City, Caracas, Jakarta, Mumbai, Calcutta, Manila, all in high-risk areas for natural disasters. As you can see, global warming, very controversial regarding its potential for disasters. Right now we're dealing with avian influenza. We have a much different world now. It's a global community. Diseases in Africa 100 years ago you'd never hear about. Basically, you can be in Kinshasa, in Belgium in 8 hours, in Brussels, and another 8 hours in New York City. SARS was a wake-up call. Once again, public communication, avian influenza, a concern not only for the public health community, but very unusual in a general scientific publication. The immediate future, we're right here, right now, in undergoing probably the biggest revolution in our lives and in technology since the Industrial Revolution in the 1840s, 1850s. It's just a lot smaller, not factories, but genes and proteins with great potential to help people. All this research is going to revolutionize the care of cancer, cure of cancer. For the first time we're talking about, and genetic disorders, infectious diseases, but with all things for good, we found, unfortunately, they can also be used for evil. I have a lot of stories on Larry Wayne Harris here, who you will all be very happy that this guy, a member of a neo-Nazi group, tried to get a hold of anthrax and plague, graduate student in microbiology at Ohio State. But apprehended. Final thought, bottom line is, and it really concerns me that we are so focused on things, drugs, storehouses, equipment, things you can actually touch, and getting the concept of epidemiology, public health, preventive health to decision makers it's a very nebulous thing, and I'll never forget, and I won't mention names, but trying to explain to a politician why we need $1 billion, and he said, "Well, you CDC folks, you want to collect data? Are you doing research in the midst of human suffering?" And I said, "No, sir. This is data to allow you and the president to make better and more effective a decision. But collecting information. But what's the outcome? Well, the outcome is preventing disease. So that nothing happens because I had to use layperson's language." And he says, "Well, expletive, I am not going to spend $2 million for nothing happens." I said, "We've got a lot of education to do here." Thank you very much, and I'm sorry I went over time. Okay.
We have time.
Like I said, I'll be here the whole day.
Okay. We have time for questions now, and also Dr. Noji says he'll be here the whole day, so we'd also encourage folks to come up and talk to him one-on-one. Do you have anybody?
I guess I'm the first bold one. You had mentioned at one point in your talk that the budget for dealing with terrorism and health effects thereof was higher than the budget for dealing with HIV/AIDS. And I wonder, just in the changes that you've seen, particularly over the last 5 years, how has the political capital in addressing terrorism for politicians, for being able to say, "See, we're trying to protect you," have you seen resources being taken away from other just as pressing or more pressing health needs? And if so, what are folks within the public health community doing about that?
I can't, the budget, I can't talk about NIH or FDA, but at CDC, there hasn't been a decrease in HIV, heart disease, diabetes, really injuries, the really major killers of the major public health problems in this country. I am concerned about level funding in some of these issues, particularly chronic disease and mental health. But it's been the incredible skyrocketing of a budget in 3 years from $150 million to $3 billion. And I just don't know if you can say it's taken away from other research priorities, because the reason I say that is I don't think that those other budgets would have increased anyways. In fact, they may have decreased in some cases, like injury prevention. But that is a good question, and the answer that people at NIH usually give is that the research on biodefense, chemical, radiological has a dual use, that the output will solve many, quote, normal health problems. And there is an element of truth to that, because when you look at really fundamental changes in advances in healthcare and medical care, they've come from war. You look at what came out from the World War II, Korean War, Vietnam War, things we take for granted now. Incredible changes, particularly in the surgical fields and in trauma resuscitation, are going to be coming out of the Iraq war.
Hi. Thanks very much for your talk. It was very interesting. I became attracted to academics because I thought that through education, that was the best way to impact on policy. You get information, you get knowledge, and you share it with people who are making decisions. But I think that has failed. I think it failed New Orleans. And I think the tsunami is also another example of where using education as your primary tool was not successful. And I see even in our local community that there are difficulties in policymakers grasping disaster as an outcome. It's something that is a low frequency but a high cost event. And so I wonder what you think in terms of what would be more successful in getting our various levels of government from local up to international to really become more prepared. We can't, it seems like we do everything reactionary. So we have an anthrax, so now we prepare for an anthrax. We have a flood, so now we're going to prepare for a flood. But there's all these disasters waiting to happen. Thank you.
Well, that's why Katrina was very upsetting, very emotionally for me, and because so much attention had been spent. There's a disaster center at Tulane School of Tropical Medicine and Public Health. FEMA has, over a 20-year period, I don't know, $1 billion on flood control, dike studies in Louisiana. So not just in healthcare. All in health is not the most important in disaster response, as heretical as that may seem. But it's a good article that this could be. You've got changeover in staff. So you train a group of people, and if they're in government, as they're promoted up the civil service chain, they leave the area of responsibility for disasters. If you have good people at the operational level, the politicians and the higher level, they're not trained. And they spent a few $1 million with this new national response plan, training, but totally threw out the door when the president says, I want this. The military is in charge now. What do you do? Things are just so chaotic and decisions are being made. And even people who are educated, they don't have the authority to bring into, to use that education. Train the trainers also. That's something that we've used internationally, hasn't worked, because once again, the people that attend these training courses are nominated by their governments, and oftentimes, I hate to say it, the persons that are nominated are not the persons responsible back home for emergency management, and they may like a nice vacation to Honolulu or Tahiti, where the course is. Yes, that whole how to actually bring to fruition all of the resources on education and get it used. I mean, otherwise, why do we educate people? Funding also is up and down. We only have money after a major event. Earthquake education. After a San Francisco earthquake, boom, it goes up, and then it starts to go down. And my concern is we've now got 300 centers of excellence, excellence in disasters in the U.S. Because there's money. But if we don't have a terrorist attack in the next 10 years, I can guarantee you the funding level will not be the same. And getting sustainability of that money for research and education. But that whole area of we train people, we educate people. I mean, I've given up on, for example, because for 20 years I've been telling people dead bodies don't cause epidemics. Epidemics are rare after natural disasters. They're a great threat in a refugee war situation. But time and again, I've got so many newspaper articles of epidemics of Ebola virus breaking out in St. Louis during the Great Midwest Flood of 1993. And what was especially damaging in the tsunami is when you had two well-known physicians in a helicopter flying over Phuket or Sri Lanka. Who's that doctor on CNN? Rajiv and Bill Frist. And they were saying, oh my God, epidemics are going to be breaking out, and diseases which hadn't been seen there in 200 years, and diseases which have never been seen there, and if they've never been there, they're not going to be there 2 days after the tsunami. And when two credible figures like that say incorrect things, that really made me throw in the hat. And now I think that those, what we call the myths of disasters, I just, going to take that as a part of a disaster that we're going to have to address. Yes?
Early in your presentation, you spoke about making decisions on incomplete information. I was hoping you could elaborate a little about that, based on like what your process is that you would go through, or like training guidelines that you would give to new staff members.
Is your question how it was done or how it will be done in the future?
A little bit of both.
Well, at first, number one, we were dealing with a public relations disaster. If you may recall, you had no one in the government believed that was a case of anthrax at a computer terminal at the AMI building in Boca Raton. Number two, and thankfully, you had a very courageous physician who made the diagnosis in Florida that this is anthrax, ridiculed by her colleagues. She stuck to her guns, and it was anthrax. And then the chief executive of our department, who shall remain nameless, said that this fellow got anthrax fishing in North Carolina. And so CDC, we had started off from a difficult public health communications point, but our problems were in a situation of not knowing what the disease is, not knowing risk, not knowing how to answer questions like, will this spread all over the country? If someone coughs on me, do I have to wear a mask? Can it be re-aerosolized? Because the newspapers were publishing all sorts of stuff. Many physicians are, like Larry Altman, former EIS officer at CDC, they read, they know the medical literature, and public reads that, and we were overwhelmed by calls, and we would say stupid things like, "No, well, I wouldn't do that," but like, no comment, which is the worst thing, and it's probably even worse than saying the wrong thing. And so, now what we do is every single, we have a 3-week course for all entering EIS, Epidemic Intelligence Service, for those of you who don't know, 2-year training program, applied epidemiology at CDC. They have just 3 weeks of classroom teaching, and now we have a whole day on risk communication, health communication, not just for disasters, but a hantavirus or a West Nile virus. And fortunately, we are just a couple miles from CNN, and pro bono, CNN sends a real reporter and television, and every single EIS officer is interviewed. We now give, since Dr. Gerberding has been the boss, press conferences with the written and television press, fairly large numbers in an auditorium. We now have 2 teams, A and B teams, where scientists, let's say we have a situation like this, the scientists who are working on characterizing the virus would be sheltered. They would have no contact with the press, and then there would be a scientist who have credibility, because one thing we learned is if you have a source that is not credible, the public won't believe it, and you need finally they had people like D.A. Henderson and Tony Fauci become the spokesmen for the department. That was one thing we learned also. So protecting the researchers, but having a credible bench of scientists to answer questions. And there are many other things too, but at least we're much more experienced now in interacting with the press and the importance of public health communication, community education as a major part of the training of an epidemiologist, which I know to many of you is, well, that's pretty obvious, but in this situation was very difficult to do.
Thank you again, Dr.